I'm pleased to be providing you this update on the treatment of Mpox. These are my disclosures. Before getting into discussion of treatment for Mpox, it's important to review the current status of treatment for smallpox virus because all of the drugs we have for treating Mpox really come from their approval for smallpox treatment. And there are 3 US FDA-approved drugs for the treatment of smallpox virus: tecovirimat, cidofovir, and brincidofovir. Of course, we haven't had any smallpox in humans for a very long time, fortunately. So approval of these drugs and of the vaccines, which I won't be talking about, has been based on the animal rule, which allows approval of drugs for human use based on results of appropriate animal trials when clinical trials in humans cannot be conducted. So prior to the 2022 outbreak of Mpox, experience with these agents for the treatment and/or prevention of Mpox was really very scant. So let's start talking first about tecovirimat, which was previously known as ST-246 and is also known as TPOXX. This was approved for the treatment of smallpox in 2018, and it targets viral protein 37, or VP37, which is required for envelopment of intracellular mature virus by Golgi-associated membranes. And so tecovirimat prevents the egress of infectious particles. And it's broadly active against the orthopox viridae. It's active against smallpox, against Mpox, against cowpox, camelpox, and so on. It's worth going through some of the preclinical data because it's going to become important when we come to talk about one of the recently concluded clinical trials. This slide shows the in vitro activity of tecovirimat, or ST-246 as it was known, in vitro against Mpox. And the top 4 rows here in this graph show the effect on West African isolates, which belong to clade 2, the clade responsible for the 2022 outbreak. And the bottom 3 rows show the effect against Congo Basin isolates, which belong to clade 1. And clade 1b, of course, is the variant that's causing the current outbreak in the Democratic Republic of Congo and neighboring countries. And what you're looking at here is a plaque reduction assay. You see how many plaques, all these little blue dots, are present when there's no drug, and then with there are decreasing concentrations of drug moving to the right. So you see at the highest concentration, a dramatic reduction in the number of plaques. It never completely prevents all infection, but substantial reduction. And then more and more plaques as you get to lower drug concentrations. And then you take this data and graph it, and you get a drug inhibition curve. And you can see that the 50% inhibition concentration is somewhere between 0.01 and 0.1 micromolar, regardless of whether we're talking about clade 1 or clade 2. Similarly, in a non-human primate model where macaques were experimentally infected with a lethal dose of the Zairian 79 Mpox strain, so this is a clade 1 strain, treatment with tecovirimat initiated 1 or 3 days post-inoculation was highly effective, 100% effective in preventing death in these macaques. And led to reductions in virus load, as you can see from the yellow and blue bars compared to the black bars in panel B, and clearance of lesions, a very small number of lesions as compared to the control animals, as you can see in panel C. And then in the study that was really essentially the study that got this drug licensed, looking at tecovirimat in both a rabbit and non-human primate model of Mpox infection that was published in the New England Journal of Medicine 6 years ago now. We'll just focus on the non-human primate results in the top 2 panels. You can see in panel A dose ranging study where placebo is shown in black, and then the lowest doses were not much more effective than placebo, but the higher doses at 3 and 10 milligrams led to about 80% survival. And then a second study that looked at even higher doses showed at the 10 and 20 mg per kilo dose, there was complete protection of the monkeys from lethal challenge. And then when you looked at this study in a tree diagram, you can see how the 3, 10, and 20 milligram doses were highly effective in preventing death in the non-human primates. This study also included some preliminary PK studies in people that showed that overall the drug was well tolerated, and there were no serious events or deaths from administration of the drug. This is all in asymptomatic healthy volunteers. Well, what's been the human clinical experience with tecovirimat with Mpox? Before 2022, almost all of the experience had been in treatment of severe or disseminated vaccinia virus infection, people who had been vaccinated against smallpox and had, with the live virus vaccine, and had dissemination of the vaccine strain. But there has been accumulating anecdotal experience in the treatment of Mpox, and there are now 2 clinical trials sponsored by the National Institute of Allergy and Infectious Disease, the PALM-07 study done in collaboration with the Institut National de Recherche Biomédicale in the DRC, and the STOMP trial being done through the ACTG, which is known as ACTG 5418, internationally, and I'll describe both of those studies. There are also additional randomized trials underway, including the Unity, Platinum, CAN, and Epoxy studies, but there aren't any results of those trials to talk about just yet. There have been several cohorts that have reported results since the 2022 outbreak. One from Atlanta was a case control study that used propensity score matching to line up people who did or did not receive tecovirimat. This is a very small study, just 56 people with HIV who received early tecovirimat matched to 56 controls who either were treated late or didn't get treated at all. And the primary endpoint was Mpox progression within 7 days after symptom onset. The study found that progression occurred in only 5.5% who received early treatment versus nearly 27% in the late or no tecovirimat group. And among the 14 matched pairs where one did and one did not have a primary endpoint, only one of them had, who received early treatment had progression versus 13 who had late or no treatment had progression, and that was highly significant with an odds ratio for progression of 13, which is pretty substantial, but as you can see, with very wide confidence intervals, not surprising given that there were very small numbers. Remember, this is a non-randomized cohort study. Somewhat different results were seen in a slightly larger cohort study done in Seattle. This study compared the outcome of treatment in 80 people versus the 35 who received no treatment among this total of 115 participants with Mpox, not all of whom had HIV, in contrast to the Atlanta study. And here, if we look at those with severe disease, if treatment was started within 5 days of symptom onset, and we can look at this row here, you can see that there was a statistically significant difference in the median days to improvement, but not in median days to resolution that failed to achieve significance. But otherwise, if your treatment was started more than 5 days later, there was no significant difference. For people with non-severe disease, there really was no difference at all for any of the endpoints, although there was a trend towards near significance for time to resolution among those with non-severe disease, even if they started treatment somewhat later. So that brings us to the PALM-07 study, and this slide shows the study design. This was a randomized, double-blind, placebo-controlled trial of children and adults with laboratory-confirmed Mpox of illness of any duration, so long as active lesions were still present, conducted at 2 sites in the Democratic Republic of Congo. Participants were randomized equally to receive tecovirimat or placebo for 14 days. And because both children and adults were included, dosing was weight-based, with the typical adult dose being 600 milligrams PO twice daily. Participants were hospitalized for the duration of treatment. So everybody who was in the study was hospitalized and given the study medication under direct observation. The primary outcome was time to complete lesion resolution within 28 days, and secondary outcomes included mortality, safety, symptom resolution, and viral shedding. Preliminary results have been released through a press release from the NIAID and from SIGA, the company that markets tecovirimat. There were just under 600 participants enrolled. In addition to being randomized to study treatment or placebo, they all received supportive care, including nutrition, hydration, and treatment of secondary infection. The drug was safe and well tolerated with no drug-related serious adverse events. Mortality in the study overall was substantially lower than anticipated, and time to lesion resolution was much faster than expected in both groups. As a result, there was no significant difference in time to healing of skin lesions and no significant difference in mortality, a somewhat surprising and disappointing result, especially considering the animal studies that I've shown you previously. However, one point mentioned in the company posting, but not mentioned in the NIAID press release, was that there was meaningful improvement, not clearly defined, observed in participants receiving tecovirimat within 7 days of symptom onset and in those with severe or worse disease. Now, that does line up a bit with what I showed you from the Seattle study, where those who were treated early and had severe disease did achieve a significantly faster time to improvement, although not to time to full resolution. Let's talk now about the STOMP trial, which is still ongoing. This trial is a double-blind, placebo-controlled international trial, but it also includes an open-label arm. People with severe disease, pregnancy, those who are under age 18, or have severe immune compromise, or are receiving potent CYP3A4 inducers, are offered enrollment into an open-label arm where everybody gets tecovirimat. The randomized component is for adults with mild to moderate Mpox, and they are randomized 2-to-1 to oral tecovirimat or placebo for 14 days. There is again weight-based dosing, as was done in PALM-007. The participants in the blinded arms who demonstrate progression after 5 days can cross over to the open label arm. So there's a built-in protection in case people are progressing if they happen to be randomized to the placebo arm. The projected sample size is 530 participants in the randomized arms. The study at present has reached a little more than half of that goal. The primary endpoint is time to resolution of skin and mucosal lesions, and secondary endpoints include safety, viral clearance, progression, and also pharmacokinetics in children, because we know little about the PK of tecovirimat in people under age 18. This study, as I mentioned, is ongoing, so we don't have results from it. This study is enrolling mostly people with clade 2 infection, although there may also be some people who have clade 1 infection, and it'll be very important to see if there are differences in the results from this study versus the PALM-007 study, but the negative results of PALM-007 make this trial even more important. Now, there has been resistance to tecovirimat reported. Mutations in the vaccinia F13L gene, which is the homolog of VP37, are known to confer resistance to this drug, and up to 50-fold increases in the EC50 due to accumulation of mutations in this gene were observed to emerge in a patient with disseminated vaccinia who received a prolonged course of tecovirimat. Interestingly, in that study, the resistant viruses were found at the site of initial inoculation, not so much in the satellite lesions. Mutations have also been seen with reduced tecovirimat, have also been found in 6 of 8 people with HIV with Mpox in the current outbreak, unresponsive to tecovirimat in a series from Los Angeles. And resistance appears to arise most often in immunocompromised persons who have prolonged courses of tecovirimat, a theme which is very common in emergence of antiviral drug resistance. For example, the use of chronic acyclovir in highly immunocompromised people, leading to emergence of resistant herpes simplex virus. This slide shows a survey done by the Centers for Disease Control. You can see the states that were sampled in panel A on the top, and then those where the resistant viruses were recovered in panel B. Panel A at the bottom shows the inhibition curves for control virus all the way on the left in purple, and then these viruses with the various mutations in the gene encoding VP37, including this one highly resistant virus in red here. And then in panel B, showing the serial emergence of resistance in a person who had received a prolonged treatment with tecovirimat. And you can see the starting strain at initiation of treatment in August was susceptible, and then resistance develops over a 2-month period. I'll say very briefly a word about cidofovir and brincidofovir, which are potential alternatives. These are both phosphonate nucleotide analog inhibitors of DNA polymerase with broad activity against double-stranded DNA viruses. They are used in some settings for treatment of cytomegalovirus, adenovirus. They've been shown to have activity against Ebola, as well as the orthopox viruses. Both are approved for treatment of smallpox under the animal rule, as I mentioned at the outset. Cidofovir has to be administered intravenously, which is a major disadvantage, and has the significant dose-limiting problem of nephrotoxicity. Brincidofovir is an orally available prodrug of cidofovir with reduced nephrotoxicity. Phase 2 trials showed a reduced risk of CMV in stem cell transplant recipients, but a phase 3 trial failed because it showed excess mortality, and subsequent trials of this drug for CMV and adenovirus were halted. There are anecdotal reports of the use of brincidofovir for disseminated vaccinia and for prior Mpox outbreaks. I apologize for not having corrected this slide. And its current availability for Mpox is limited. It's really not been distributed at all for treatment of Mpox during the current outbreak. So just to summarize, tecovirimat availability in the United States for people with mild to moderate disease, really available through the STOMP trial. And the STOMP trial you don't have to come to the study site. You can be enrolled remotely, really anywhere in the US, as well as at multiple international sites. For people with severe disease or at high risk of severe disease who don't wish to be part of the STOMP trial, those who meet the criteria for the open label arm, the drug is available through the Centers for Disease Control and Prevention through an expanded access investigational new drug license. And for those who get treated with tecovirimat, the standard dose is 600 milligrams twice daily for 14 days. There is pediatric dosing and an intravenous formulation available. The adverse reactions for oral dosing are mostly headache with some nausea and abdominal pain and vomiting. For IV infusion, it's mostly infusion-related issues. And the big caution is that the drug should not be used in people with severe renal impairment, those with the creatinine clearance below 30 milliliters per minute, and it should be used with caution in persons with mild to moderate renal impairment and in children under 2 years of age. The drug is a weak inducer of CYP3A4. It has potential drug-drug interactions with some of the antiretroviral agents, and so that would be another cautionary note. So I'll stop there and look forward to our discussion.